Hi everyone, this is Vignesh from Easy Way to Learn Medicine. So today we are going to see the Krok 1 important questions and discussion under the topic of diabetes mellitus. First of all, we'll see what is about everything that is type 1, type 2 diabetes mellitus, and we'll see diabetes mellitus complications. So first of all, so everyone know about diabetes mellitus. We have type 1 diabetes mellitus, type 2 diabetes mellitus, and we have Modi type, that is maturity onset of diabetes mellitus, and then we have a gestational diabetes mellitus. So first of all, we'll see what is type 1 diabetes mellitus. So type 1 diabetes mellitus, which occurs in childhood or in puberty stage, that is less than 30 years. In a type 2, that is it occurs at more than 40 years. So what is the causes of type 1 diabetes mellitus? That is a autoimmune disorder. The beta cells of pancreas cannot produce the insulin. But in type 2 diabetes mellitus, there is insulin resistance to the tissues and inadequate insulin secretion. Also, the body type of type 1 diabetes mellitus patient, it will be thin. In a type 2 diabetes mellitus, that is obese type. So in type 1 diabetes mellitus, the acute complication will be DKA, that is a diabetic ketoacidosis. In a type 2, that is non-ketotic hyperosmolar coma. So in type 1, that is diabetes ketoacidosis. In type 2, non-ketotic hyperosmolar coma, hyperosmolar hyperglycemic coma. So when you see in a type 1 diabetes mellitus, serum insulin will be low. In type 2, it will be increased or it will be normal. So when you see the serum C peptide, it will be low or sometimes it will be normal in a period of honeymoon period. We call it as honeymoon period. Due to secretion of happy hormones, it will be normal. In type 2 diabetes mellitus, it will be decreased in late stage of disease. So the treatment of type 1 diabetes mellitus, it will be insulin. In type 2, we will give oral hypoglycemic drugs or agents. Sometimes we will use insulin also in a type of coma. So the type 1, which is occurs in a childhood or puberty, autoimmune disorder, that is decreased insulin secretion, body type is thin. Common acute complication is diabetic ketoacidosis, and the serum insulin will be low, serum C peptide will be low, treatment will be insulin. Type 2, there will be occurs in more than 40 years, insulin resistance, body type is obese, acute complication is non-ketotic hyperosmolar hyperglycemic coma, serum insulin will be increased or will be normal, C peptide will be decreased in the late stage of disease, will give oral hypoglycemic agents. So now we'll see what are the symptoms when you see in a patient of diabetes mellitus. Polyuria, increased urination, polyphagia, polydipsia, increased urination, increased thirst, and there will be weight loss. In type 1, there will be weight loss. In type 2, there will be in type 1 there will be weight loss. In type 2, there will be like increased body weight, there will be obese. So these are the main symptoms for diabetes mellitus: polyuria, polyphagia, polydipsia, and weight loss. So what are the diagnostic criteria for diabetes mellitus? So when we see fasting blood glucose level, the normal which is less than 5.5 millimole per liter. So what is the normal level of blood glucose level in blood? That is 3.33 to 5.55 millimole per liter. So the fasting blood glucose level, that is a normal range, that is less than 5.5 millimole per liter, or we can say it as 100 milligram per deciliter. 2 hours postprandial value, that is less than 7.8 millimole per liter, that is 140 milligram per deciliter. When you take random blood glucose level, that is less than 11.1 millimole per liter, that is less than 200 milligram per deciliter. So this is the normal value. When we see pre-diabetic, the fasting blood glucose level will be 5.5 to 6.9 millimole per deciliter. 2 hours postprandial, that is 7.8 to 11.0 millimole per liter. When we say diabetic, more than or equal to 7.0 millimole per liter, and there is more than or equal to 11.0 millimole per liter. We call it as diabetic. The patient is diabetic. So what about HbA1c? The normal range, normal which is 5.6%. When there is pre-diabetic, that is 5.7 to 6.4%. When the patient is diabetic, because when there is greater than or equal to 6.5%, that is diabetic patient. So now we'll see the complications of diabetes mellitus. So the patient will have microangiopathy or retinopathy, because high level of glucose will affect the blood vessels in the eye, so we'll call it as retinopathy or microangiopathy. Also there will be diabetic nephropathy. High level of glucose will affect the kidney blood vessels, that leads to diabetic nephropathy. And third one, that is diabetic neuropathy. The patient will have loss of sensation, loss of temperature in the extremity, call it as diabetic neuropathy. So this one is microvascular complication. Also we have macrovascular complication, that is peripheral arterial disease. So when the patient is having peripheral arterial disease, that is like non-healing wound, or that lead to complication. And coronary artery disease, the patient will have myocardial infarction, stable angina, recurrent infection. So the micro complications, microvascular complication, that is microangiopathy or retinopathy, diabetic nephropathy, diabetic neuropathy, and macrovascular complication, that is peripheral arterial disease. The patient leads to like gangrene, and the coronary artery disease, MI, stable angina, and also patient will have recurrent infection. So now we'll move on to the questions. So the patient is insulin dependent diabetes mellitus, so that is type 1 diabetes mellitus. As when administered insulin, after a certain period of time the patient developed fatigue, irritability, excessive sweating. What is the mechanism of such presentation developing? So that is hypoglycemia. There is decrease glucose supply to the brain, so that is starvation of carbohydrate, starvation of the brain. So the second question, prior to glucose utilization in cell, it is transported inside the cells from the extracellular fluid through the plasmatic membrane. This process is stimulated by the following hormone, that is insulin. So there is a gate, this is a cell. So for glucose get into the cell, we need a key, that is insulin. When the insulin is attached to the receptor, it will open the gate, so the glucose can get into the cell. So the third question is, the patient is having visual impairment, so that is microangiopathy or retinopathy. Examination revealed obesity is present and her fasting glucose level is, she is hyperglycemic, and diabetic complication, so that is microvascular complication, that is microangiopathy. The fourth question, the patient is diabetic mellitus, suffers from persisting non-healing surgical wound. What is the sign of disturbed tissue trophism? What is the cause of such disorder? So when there is a high level of glucose in the blood, that affects the blood vessels, so it also like disturbs in the formation of healing, so there will be like persistent non-healing wound, so that is a disruption of protein metabolism regulation. So the protein metabolism regulation, that is nothing but, so the glucose has to get into the cell, that has to change into ATP, so there will be disturbed protein metabolism regulations. The fifth one, which is the 15-year-old patient has a fasting glucose level that is 4.8, okay, and 1 hour later the glucose is 9, which is increased, and 2 hour it is 7, and 3 hour it is 4.8. So primarily it was 4.8, after 1 hour it is 9, after 2 hour which is 7.0, after 3 hour which is 4.8. So fasting glucose, it should be 5.5 to 6.9 fasting glucose, 2 hour 7.8 to 11.0. So in the question they gave fasting glucose was 4.8, so it was slightly in the range of pre-diabetic. After 2 hours it was 7.0, so in between the 8 to 11, so that is a pre-diabetic or subclinical diabetes mellitus. So primarily it was low, after that it was decreased, and then it decreased again, and it decreased again. So you can check before I explained about pre-diabetic, that is a subclinical diabetes mellitus. So in the patient, female patient with a history of a diabetes was hospitalized in the pre-coma state for diabetic ketoacidosis. This condition is caused by an increasing following metabolic level. So when there is diabetic ketoacidosis, there will be increased ketogenesis. So that is there will be increased breakdown of fat, increased breakdown of fatty acids, that leads to increased level of ketone bodies, increased level of acetoacetate in the blood. So the body thinks that there is no more glucose present in the blood, so which initiate the ketogenesis, so that will be breaking down of fatty acid from the adipose tissue. It breaks down the fat, that will be releasing of increased level of ketone bodies and increased acetoacetate. So insulin is needed to glucose get into the cell. So when there is insulin is absent but glucose is present in blood, but the cell think that there is no glucose in the body, so which initiate the ketogenesis process. So there will be increased amount of ketone bodies and acetoacetate, so that lead to diabetic ketoacidosis. According to result of glucose tolerance test, a patient has no disorder of carbohydrate intolerance. Despite that, glucose is detected in patient urine, and patient is diagnosed with renal diabetes. So what renal changes was glucosuria in this case? So when there is a high level of glucose in the blood, that will be excreted through urine. So we call it as glucosuria, decreased activity of glucose reabsorption enzyme causes glucosuria, but blood glucose level is normal. That is renal diabetes. The blood of a patient with a diabetes mellitus shows increased content of free fatty acid. Name the most likely cause of this. That is increased activity of adipose triglyceride lipase, that is fatty acids, by the process of ketogenesis. So ninth question. So the diabetes mellitus, during diabetes mellitus and starvation, the number of ketone body in the blood increases. These bodies are used as a source of energy and synthesized from following substance. So that is acetyl CoA. From the acetyl CoA, it changes to it enter into the ketogenesis, and it changes to acetyl CoA. From the acetyl CoA, it changes into acetoacetate ketone body. So initially by the acetyl CoA, it comes from the pyruvic acid cycle, and then it enter into ketogenesis process. The patient is diabetic mellitus after an insulin injection, lost his consciousness and developed convulsions. What will be the result of biochemical test of blood glucose level in this case? The patient diabetes mellitus after insulin injection, the patient went to hypoglycemic coma. So normal level is 3.2 to 5.5. When patient is going to coma, the least level is 2.5. So that is 2.5 millimole per liter. The patient is hospitalized in the coma state. The patient has 5-year-long history of diabetes mellitus type 2. Objectively, respiration is noisy, deep, with acetone breath order. So that is a point. And the blood glucose, which is 15.2, severely increased in the presence of ketone body. That is a DKA, diabetic ketoacidosis coma. On your physiology class, professor asks you to report the effect of various body hormones and neurotransmitter on the metabolism of glucose. You begin your report with the statement that the use of glucose is preceded by the absorption through the placental membrane from the extracellular matrix into the cell. Which of the following hormone is most likely to respond for the glucose uptake by the cell? That is insulin. So it is like direct question. So thanks for watching. We'll continue to the next topic. Thank you. Thanks for watching.